Hello and Assalamu alaikum. Ultrascan Diagnostics here. This is the CBCT of the patient that you had requested. The area of interest is the upper right canine, the upper left lateral incisor, the lower right 5, 6, 7, and the lower left 5, 6, and 7. Now this is the 3D rendering. These three spots that you see are expecting that these are some form of amalgam or some form of metallic elements that have embedded themselves into the gingiva. On the panoramic view, you can very clearly see that we've got severe periodontal disease, we've got periapical radiolucency, we've got endodontally treated teeth, and you've got edentulous spaces present as well. Now we're going to take you, because this is an implant planning report, but we will take you through each and every segment that we see as problematic. The upper right, starting with the upper right floor. As you can very clearly see, the upper right floor is grossly carious. We've got two canals. These two canals are from fused roots, and you've got a periapical radiolucency present here as well. Just to give you an idea, the estimated working length is going to be for this tool at 21 millimeters. This is the upper right canine. I'm going to zoom in for our current doctor. There we go. So this is the upper right canine. As you can very clearly see, there's a periapical radiolucency right here. And this periapical radiolucency is extending from the apex all the way to the mid-root level on the palate. We don't see any cracks or fractures on this view, but you will observe for a crack or a fracture on the axial view. Moving to the lateral incisor, the lateral incisor is grossly carious. You would advise that this is just to be the left. Now this is endodontically treated with very severe periapical radiolucency, which is perforating the buccal cortical plate as well. So this needs to be addressed as soon as possible. This is the central incisor. The central incisor is also root canal treated. This is also a BDR, but you can clearly see that this periapical radiolucency is actually extending palatally. So the one that was previously before it, this one was buccally, as you can very clearly see here, with buccal perforation, the periapical radiolucency, and this is the interradicular area between the between the 1 and 2, and here you can clearly see that the bone is very severely resolved. And we move on to the upper right first, upper right central incisor. You can see that the periapical radiolucency is now draining palatally. Moving to the central incisor, on the upper left segment, we've got endodontically treated tooth, but again a periapical radiolucency which is perforating the cortex here. This radiolucency that you see is the incisive foramen. The upper right lateral incisor, is again endodontically treated, and here you can see you've got a periapical radiolucency perforating the cortical plate here as well. The upper right canine, this canine is has a periapical radiolucency, but not perforating the apex at the moment. You can see that the estimated working length of this tooth is going to be roughly 24 millimeters. Now moving to the lower right hand quadrant. The lower right hand quadrant, the doctor has advised us to implant plan the lower right 5. However, we feel like the lower right 5 is definitely endodontically treatable. It is savable. We've got one single canal, we've got good bone support, and at the same time we've got relatively better tooth structure. The estimated working length is going to be 18 millimeters. This is the lower region of the lower right 6. The lower right 6 has estimatedly 7 millimeters of ridge width with 15 millimeters of ridge height. As you move to the region of the 7, here you can see we've got a very deep lingual fossa. So hence drilling in this area needs to be very mindful. Even though we've got a significant distance from the crest all the way to the inferior alveolar nerve, which is approximately 13 millimeters, and the width is 8.3, but we cannot perforate while drilling this area, so we would advise placing a shorter implant. We've done an implant planning report which we will share with the doctor. Moving to the lower right 5, the lower right 5 is carious but non-carious. I mean, nothing which is involving the pulp. This is restorable. No periapical radiolucency. These are the medias present of the lower left six. I mean, this is the mesial media and this is the distal media. We've placed in a implant which can be placed immediately after the extraction. We've got 9.3 of ridge width with a good 16 millimeters of ridge height. In the region of the 7, again the ridge will shorten and we've got a deep dimple fossa, so we would advise placing a shorter implant. We've got 7 millimeters of ridge width with approximately 10.7 millimeters of ridge height from this point and approximately 13 millimeters of ridge height from the maximum height. Now we're going to move on to show you how we have placed all the implants. This is the 3D rendering. So here we go. These are the implants we have placed in the 6 and the 7 on the lower right, the 6 and the 7 on the lower left, and the upper left lateral incisor and the upper right canine region. These are all the implants. As you can see, these implants have been placed. We will share a report. These are the ideal location based on the CBCT. These are CBCT guided and prosthetically guided placements, but we would advise an extra implant on the anterior maxilla for better bone support and more long lasting prosthesis. Thank you very much.